what do I do if I'm trying to DIY this thing?
The first thing I would do is say a prayer, honestly, for the Medicare gods.
Hello, everyone. This is Matt Feret, author of Prepare for Medicare and Prepare for Social Security Insiders Guidebooks and online course training series. Welcome to another episode of The Matt Feret Show, where I interview insiders and experts to help light a path to successful living in midlife, retirement, and beyond. Olivia, welcome to the show.
Yeah, good morning. Thank you for having me. I'm really excited. I actually was looking at some of your other series and the shows that you've had. You have a lot of really intelligent people on here. So I'm really excited to be asked on today and really honored for sure.
Well, thanks. That's really nice of you. Let me just clarify. I have a lot of intelligent guests. I think that's what you meant to say.
No, again, you and I have gotten to work with each other in the past, and I'm really excited today to kind of roll up our sleeves and talk shop. I know you are incredibly knowledgeable in a lot of this stuff as well, so it's not really often you get to talk to people who are excited about Medicare and excited about insurance. So I'm really excited today to be able to do that.
Well, that's awesome. And yeah, so this is going to be a special kind of 2023, 2024 Medicare edition, released separately. And so let me start with my normal question. Tell everybody what you do, how long you've been doing it, and how you help people.
Sure. So my name is Olivia Richardson. I'm currently serving as the Vice President of Corporate Alliances at Senior Marketing Specialist. We're an insurance brokerage. We have about 10,000 agents across the entire United States, and I've personally gotten to work with almost all of them. I measure my time here by AEPs, which we're currently going through right now. And so this will be my 11th AEP in the industry. So I've kind of seen, we've been going through we'll get into it, lots of changes. And so I've got to kind of see the evolution of what's been going on throughout the last 11 years with Medicare. My primary focus and what I've done to kind of get excited and passionate about this topic, because again, you don't talk to a lot of people who enjoy the research, but my primary job here at Senior Marketing Specialist has been to train advisors. My role and what I want to do is I always want to make sure that mom, dad, brother, sister, grandma, grandpa, that everybody's able to get access to healthcare. And the way that I found I've been able to accomplish that on the mass scale has been to train the advisors and make sure advisors really know how to best serve beneficiaries and how to best serve their clients. So that's where I've been able to focus a majority of my time is by training better advisors. And like I said, it's my 11th AEP doing so, and I've really enjoyed it.
Nice. So this is the annual election period, or the AEP, and even sometimes Medicare messes up and calls it the OEP, the open enrollment period. It's not, but basically it's the time period between October 1st and then October 15th to December 7th, where people can make changes to their Medicare coverage. Not all of it necessarily, but a lot of it. And in my books, I have this little section, actually it's a chapter in the end, called Annual Housekeeping. And that's my way of saying, okay, not only do you have to make your decision first, but what you may have picked at age 65 or 67 or whenever you went on Medicare may not be what you need at age 72 or 75. So talk to me about what that time period, what people should be doing during this time period.
Well, it's interesting that you say, and I agree with you, it's, what you picked at 65 may not be what you need at 72. This year, what you picked at 75 or 65 may not be the same plan you needed at 66. This time of year, obviously, because with Medicare Advantage plans and prescription drug plans, you have to have special circumstances to switch during the year. And there are not a ton of these circumstances available to majority of people out there. So this time of the year is really your only chance, without getting into OEP, is really your only chance to review your plans, review your medications, review your lifestyle changes, and to make sure that that plan's still going to work for you the following year, because you're going to be stuck with it for the next 365 days. And you have about an 8-week period, not including the kind of the looking period, the first 2 weeks, October 1st through the 14th. You don't really have a lot of time. There's Christmas, there's Thanksgiving, there's a ton of other holidays in there. And that time frame is really busy for everybody. You got a lot going on. So it goes way more quickly than what a lot of people anticipate. So it's really important that you get in there early, talk to experts early, do your research early, so that you're not left December 6th saying, oh man, I haven't even started looking at this stuff yet, because it can get overwhelming pretty quickly.
Yeah, and that's a good distinction you made too. So when I
Mhm.
said it a little earlier before, I kind of flew right by it, but you pulled
Sure.
it back. So October 1st is when
Mhm.
insurance companies and really insurance agents are allowed to talk about the benefits and what they may be and the types
Sure.
of plans for the next year.
Mhm.
This is called between the 1st and the 14th is basically the time you can market it, advertise it, talk about it,
Mhm.
but you
Mhm.
can't buy anything. You can't actually enroll in anything as a consumer. Starting October 15th, that's the first day that you can actually begin to enroll in something effective January 1st, and that
Sure.
ends at midnight on the 7th of
Sure.
December.
Sure.
So there's time and planning. To your point, there is a little small window, and
Yeah.
it doesn't even start on October 1st because you can't buy
Mhm.
anything till the 15th. Something
Sure.
happens before then, though, that's
Mhm.
really important, right, for consumers, and that's at the end of September. What is
Mhm.
that?
So at the end of September, age or consumers will start to get letters called ANOCs. They're called annual notices of change. So in the industry, we try not to use jargon, but everything is hyphenated and abbreviated. So they're known as ANOCs. But what these annual change letter reviews are is basically a letter explaining to the client, hey, these are the changes coming to your plan this year. And it's several pages long. There's a lot of verbiage to it. It's a lot of numbers. And it honestly kind of looks like trash, kind of looks like junk mail. So a lot of people will throw it away or just breeze over it and really don't pay attention to it. But it's a really important notification to let you know what you should be expecting from your plan come January 1st.
So if I get this big thing in the mail, does it come in email?
Some carriers you can elect to get your stuff via email. That option is not really heavily utilized. So majority of the time, and honestly, all the time, it is going to come in a mail format.
Okay, so I get this big stack of paper that I don't want to read. What should I read if I don't want to read the whole thing? Or what should I breeze through? What should I be looking for?
Yeah, what if you're going to rely, and this is if, again, you have a couple options when you do receive this letter. If you are wanting to be self sufficient and you're a strong, independent beneficiary, you do have the option to kind of review the information on yourself. And if you do want to go that route, then there are portions of the ANOC letter that'll basically look like a summary of benefits. We'll say, here's what your hospital copay is going to be this year, here's what your premiums are going to be this year. But it does exclude a lot of the information like formularies and things like that, provider directories. There are things that are not going to be included in that letter that you really do need to make sure you know to make an educated choice come AEP. The other route is honestly one that I typically recommend, and that is to be paired up or to work with an advisor who is able to look at that plan, explain to you, and by an advisor, I mean an insurance agent,
Yep.
but somebody who is able to look at those changes. They're able to look at your prescriptions. They're able to look at formularies, your providers, and make sure that everything that's included on that piece of paper, but then everything that's not, to make sure all of that is considered when shopping for a new plan. So I'm pro agent, obviously, with my job, my lifestyle, but I've seen what happens when people don't involve an agent. You don't know what you don't know. I mean, Medicare can be incredibly confusing when you start adding these letters, when you start adding carrier advertisements. It's not an easy maze to navigate. And so to have somebody there who's experienced, who is unbiased, and can give you real advice about what you should look at least going into the next plan year, is worth having that guide.
And I say this in my book and elsewhere.
Mhm.
If you're on a Medicare Advantage plan or you have a standalone Medicare Part D prescription drug plan, your plan will change every year.
Yes.
Something will change.
Mhm.
I've never seen an example of any insurance product in those two lines that doesn't change.
Mhm.
Premium, benefits, formulary, provider networks,
Mhm.
dental. I mean, the list goes on and on and on, right? So
Mhm.
for everybody out there listening, you're gonna get something in the mail. You're not gonna want to read it. You're gonna put it on your counter next to your fridge and stare at it for a
Mhm.
while, and you're gonna put other mail on top of it. That's the one you got to read, and you got
Yes.
to open it up. But
Yes.
Olivia, to your point, it's not all of that's in there. So
Mhm.
if I'm DIYing this myself, what else do I need? What else do I need to do? Do I need to go on my carrier's website and check the provider directory, see if my docs are still on?
Sure.
Do I go
Yeah.
on Medicare.gov and type in my new prescriptions if I've had them? Like, what do I do if I'm trying to DIY this thing?
If you're trying to DIY it, the first thing I would do is say a prayer, honestly. the Medicare gods. And to your point, things do change. Sometimes the changes are for the better. Sometimes the benefits are better. They get richer, but a lot of times they're not. So there are tools and resources out there. If you are somebody that's wanting to, again, DIY it, to be able to do this on their own. Again, Medicare.gov is a consumer-facing tool that does have some excellent resources. You can put in your list of medications. You can put in sometimes the providers in there. The problem with Medicare.gov is that, unfortunately, even though it is a government-associated website, it's not always the most accurate, and there's not a whole lot of accountability to ensure that it's accurate. If you make an enrollment on there and the information either isn't accurate or changes and you weren't notified of those changes, then there's really all you have to do at that point. I mean, you call 1-800-Medicare, which is a call center located in Louisiana, because the cost of living is lower there, so they can pay their people lower there. So you're calling that call center, and somebody's following a script to try to help you and navigate you through what mistakes were made or not made. So again, there are tools out there. Medicare.gov is one of them. Carrier websites, they are incredibly helpful if you're wanting to go ahead and see, is my hospital still in network? Is my specialist still in network? You absolutely should be using those tools. But if you're doing that, then you're still kind of focusing in on what you currently have. If you were to do this on your own, then you might want to be able to use resources. Like, you'd have to use multiple websites to really compare plans to make sure that you're on the one that fits your lifestyle and fits your budget.
Yep. You're right. And the do it yourself, the DIY piece, it's possible. It just,
Sure.
It's tough. And I'm not continually going back to my book, but I will here. It's,
well, it's a good book, so you should.
Oh, thanks. I mean, you can do it.
Mm-hmm.
It's just, when you open up, if you live in a city and you go, what Medicare Advantage options do I have? You're going to pull up 60.
Yeah.
Okay. How do I start?
Mm-hmm.
When I get, even in rural areas, you pull up a Medicare Part D plan, you're going to have 30.
Mm-hmm.
Okay. Which one do I do?
Mm-hmm.
So, all right, let me move into the next piece, right? So there are 3 ways to consume your Medicare insurance, right? The first way is I call bear with Medicare. You you stay on original Medicare Parts A and B, the red, white, and blue card, and you have to buy a standalone Medicare Part D prescription drug plan. Okay. You have to buy that from an insurance company because there isn't a federal default option that's always sold by an insurance company. And the next
I always
way
call
to do
that Medicare Part U. I heard that it was actually Dan Mangus, who's really well known in the industry, says it's A, B, D, and U because you're paying the rest of it. It's a really clever way to remember that.
Yep. I like that one. So bear with Medicare or Medicare plus U. That's funny. Either which way, right? You've got original Medicare plus a D. And the second way is the same version, except you add a Medicare supplement plan on that. And I'm going to save Medicare supplements to the end of our conversation for a couple of reasons, which will become apparent. And then the third way is to buy kind of that all-in-one combo plan, i.e. Medicare Advantage, where you've got your A and B benefits rolled into D benefits, all in this thing called Medicare Part C. All right. Now, Medicare Part C, the Medicare Advantage, those are the ones that I say change every year without fail. They're a 12-month calendar period, right? Your benefits start on 1/1, they end on 12/31. If you do nothing, it just rolls over into the next plan of the year, right? If it changes, if it goes up, if it goes down, if it gets better, if it gets worse, whatever. If you don't do anything during the AEP, you just keep getting what you're getting.
Sure.
Same with Part D, right? 1/1 to 12/31. If you do nothing, whatever they tell you, if the benefits go up, they go down, right? Your drug is on the formulary, not on the formulary. Your premium goes up, your premium goes down, whatever. If you do nothing, it will just roll over. So there is a do nothing option here. However, there are changes that are made, as I said, to both of those programs every year. But there are also changes to the way Medicare themselves make companies change their benefits.
Sure.
And those are changing every year. So let me start with Medicare Advantage first, since I think right now half the Medicare population is on a Medicare Advantage. Let's go there. Yeah. What big changes are being made either by the carrier or enforced or being told to the carriers from Medicare are happening that aren't getting much press and may be surprising to people?
Right. So I'd start off with saying, in the past 3 to maybe even 5 years, we've seen Medicare Advantage plans remain actually really stable. And so people who are having these conversations about like, do I need to shop? They may not be used to actually having to do a lot of research, may not have to been previously used to doing a whole lot of shopping. That's going to be pretty different this year. This year, we're expecting a ton of market shakeup, a ton of benefits going up and benefits going down for people. So this year, why is there so much shakeup? There's several different reasons for that. Number one, Medicare Advantage plans and prescription drug plans, a lot of the funding for those plans come from CMS, Centers of Medicare and Medicaid Services. This year, going into 2024, previous years we saw the funding just increase and increase. CMS kept giving these carriers and these plans more dollars to play with. This year, we saw it actually take a significant step back. They didn't get near the funding that they had previously and near the funding that they had expected. So we're seeing where we have to remember these companies, these insurance companies, they are for profit. Their number one concern is to make money at the end of the day. So they're not going to eat those costs. They're going to make sure they're adjusting those benefits to where they're still able to hopefully remain profitable at the end of the day. And those benefits are going to be consumed by the end consumer, the beneficiary. So some of the things that we're seeing, some major changes, I'll start with Medicare Advantage plans. Number one, you're going to see some investments in the shiny. I know that's kind of what you and I referred to it as earlier. We're going to see some investment in the shiny stuff and maybe some detrimental stuff happening to the actual health and benefits. And we call them the secondary benefits. By secondary benefits, I'm talking about those benefits that don't show up on your Medicare card or don't show up on your insurance card. You'll have your copay for your doctor, ER copay, things like that. What I'm talking about, things that you might see take some significant increases are going to be things like your specialist copays, ambulance rides, skilled nursing care, some of those things that are true and things that can cost more money.
But they don't jump out at you. Yeah, they don't jump out at you. Yeah.
Exactly. They're the ones that, they're the ones that are going to be seeing some of these increases. So you really need to pay closer attention. Now, things that we're starting to see this year continue to raise up are going to be those new and shinies. And so we're seeing huge investments being made into dental benefits. We're seeing huge investments being made into flex cards, which are like grocery benefits, over-the-counter drugs. And I'll say that when we look at the utilization of those benefits, it's actually really low utilization. Some of these plans are offering thousands of dollars a year in groceries and healthier groceries. And it gets your attention. You can get really excited about it. It's easy to sell that. But when we see people actually utilize those benefits, the utilization is quite low. So it grabs your attention, but it's not what you should be purchasing your plan off of. You really need to remember this is a health insurance. Buying this insurance is the difference between, you recovering in a hospital or you recovering, in a home or in a less than great situation. So you really need to remind yourself or be remembering that you need to pick a plan based on those benefits. A big example of that is going to be these Part B givebacks. People know this is big commercials that everyone wants to talk about.
Yeah. You used, and I know you did because we're both in the industry, yes. But you used a phrase that not everybody's going to know. So what is a Part B giveback plan?
Yes, a Part B giveback is I'm sure you're hearing about it. Everybody wants to talk about it. The Joe Namaths and the JJ Walker advertisements. What it is that the carriers are essentially saying, hey, if you enroll into this plan, then we will make sure that if you're getting your Part B, if you're paying for your Part B out of your Social Security, we'll just take less out of your Social Security. You'll see less of that being deducted from your Social Security account each month. Or if you're paying for your Part B via a check quarterly, they'll say, we're just going to bill you less. It's called a Part B give back. You're not actually receiving that money in your hand. They're just taking that money and deducting it from your Part B premium each month or each quarter. And so, and the interesting thing about those is that they are, again, when Deft Research has a lot of really valuable information. They survey the beneficiaries to try to figure out how are we thinking? What does the United States have to say about their insurance? And one of the top reasons why people are interested in shopping plans is for these Part B givebacks because they're new and shiny and they sound great. But keep in mind, again, insurance carriers are for-profit organizations. When they're using these new and shiny things, dental, travel, those flex cards we talked about, they're anticipating a lot of low utilization on those because that's what history has shown us. People don't use rebates. Part B givebacks or Part B rebates are a 100% utilization. They are by far the most expensive bell and whistle that a carrier can offer because it's 100% utilization. We can imagine if Medicare continues to see a decrease in these plans and and the price of everything continues to go up, it's very likely that carriers are going to quit offering these bells and whistles, especially that Part B rebate, Part B give back. So if you're buying a plan and that's the reason why you're buying it, you're making, if you're going from a Medicare supplement to a Medicare Advantage, especially, you're making a pretty permanent decision on something that could potentially be very temporary. So it's just extra things to consider when you're looking at buying health insurance. You're not buying a gym membership, you're buying health insurance.
Yeah, I always come back to a couple of things, and you and I have both been doing this for a long time, of you want stability.
Right.
Right. You want stability in your premium. You want stability in your network. You don't want to have to mess with it. I mean, nobody wants to mess with it every year. I get it. Yet sometimes you're forced into messing with it. And I think what you're saying is, and tell me if I'm hearing this incorrectly, is that when you make that initial purchase of, in this case, a Medicare Advantage plan, really give some thought to how long that plan has been there. What that star rating looks like.
Right.
Do the benefits look the same a year ago as they do next year, or very similar? Because you're right, there are many examples around the country of insurance companies opening up new plans with, I think I call them in the book, shiny objects. Don't get blinded by shiny objects. They'll offer $5,000 worth of dental.
Right.
Okay, that's great.
Sure.
But what do the medical benefits look like? What do the prescription drug benefits look like? You mentioned Part B givebacks. Well, I just use the industry phrase. Basically, it gives you a credit on your, right? It gives you a little credit. It's actually not $0 premium. It is $0 premium, and they don't take as much out of your Social Security check or if you have to pay it quarterly, then you have to pay less. My impression is those benefits don't always last.
Sure.
And that's what I hear. I think you're saying too, is that I've seen Medicare Advantage plans that started in 2007 and they're still here today. And I've seen Medicare Advantage plans that get introduced and 2 years later they're deleted. They're gone. And when that happens, there's a scramble. So they can't cancel you, but they can cancel the plan you're on. And when that happens, you'll get a notice in the mail that says, hey, we're no longer offering that plan.
Sure.
In other words, if you do nothing, you're going to go right back to original Medicare, and then you're forced to take action. So that's my extended way of kind of, I think, spitting back to you what I heard, which is be really intentional on the plan choice you're making on Medicare Advantage. Don't just pay attention to the bright, shiny objects. Pay attention to its stability, its longevity, and yes, its benefits. And if you've got a good reason or a healthcare reason or need some dental work done or really attracted by some of these new things plans are offering, I think what you're saying is, consider it, but make sure it's ranked in your brain the appropriate way.
And what I'm not saying is I don't want to demonize Medicare Advantage plans. Medicare Advantage plans can be fantastic options. Several of my friends, several of my people that I advise, they have Medicare Advantage plans because they looked at the benefits, they looked at the healthcare, they weighed their priorities. Where did they want to save money? Do they want to save money up front and willing to pay for it later and co-pays and other situations? Or were they wanting to work at the budget and spend a lot more up front with the Medicare supplement? So I don't want to come across saying like Medicare Advantage plans are bad. They are not. They are fantastic options for a lot of individuals out there, but you just have to know how to shop for them. And to the other point with talking about wanting stability, Medicare Advantage plans are not the only people or not the only companies or plans that have come in with that mindset. We're going to come in shiny and awesome and then get what we can for a couple of years and then we're going to get out of there. We've made our money. Now we're going to get out of there. Other plans, including Medicare supplements, have done really similar things. They can come in with incredibly low premiums, and look at how cheap we are. We're $50 a month cheaper than our competition. Come by us wherever, our plan G looks just like their plan G. But then a year, 2 years down the line, they start hiking up those premiums as well. So when you're shopping for any insurance, regardless if it's a Medicare supplement or a Medicare Advantage plan, you need to make sure you're looking at more than just new and shiny. You need to make sure you're looking at more than just premium. And again, that's why it's really nice to have a true advisor to help guide you through that. Because you as a beneficiary, how are you supposed to know that? How are you supposed to know how to shop for that? That's why it's best to work with an expert when it comes to those questions.
What other changes in the Medicare Advantage space are you seeing that aren't well publicized or well known yet that people need to be looking for when they're opening their mail or considering their current or a different plan?
Yeah, the biggest thing that can come to mind is with Medicare Advantage, but more so focuses on the prescription drug sides of things. And that's going to be check your formulary. There are some significant shakeup that on paper looks pretty cool and really awesome, but when you dig into what it actually means can be a little concerning. So prescription drug plans, we're looking at, again, when we're looking at prescription drug plans, we know those are carrier owned. There's not just like a Medicare drug coverage. You have to go through particular carriers for that. In the past, we can expect to see some significant increases in just general cost for prescription drugs this year, either by the premium of the plan or by the formulary. And I'll expand on that just a little bit. Let's start with premium. So we're seeing a huge increase across the board for drug plan premiums. And for example, last year, when we look at the national average of drug plan premium, the national average premium was about $33, give or take 50 cents. Going into 2024, that national average has almost doubled. We're seeing $64 as the national average premium. So a lot of people are going to look at that and be like, well, I have a Medicare supplement. This affects my Medicare supplement people. Medicare Advantage clients, of course, that's built into that plan. So your Medicare supplement people might be a little anxious about, well, how do I pay for the Part B premium? How do I pay for my MedSup premium? Now I have this drug premium. So those same people are going to be really attracted to what we're seeing kind of at the exact opposite of this. You're going to look at these options and be like, well, this Olivia person told me everything's so expensive, but I'm seeing a drug plan here for a standalone drug plan that's 50 cents. That's completely $0. And so that's going to be really attractive to people. It's so imperative this year, regardless of what plans you've been on the past, please, please, please run your drug list. And when I say run your drug list, what I mean is look at your prescriptions you're taking that are long-term prescriptions for your chronic conditions and make sure that that drug plan is going to continue to cover them at the costs that you are comfortable with and familiar with. When we're seeing these plans take their premiums to next to nothing, then they're making up for that cost somewhere. And oftentimes that means a lackluster formulary or maybe taking advantage of the entire deductible when maybe they haven't in years past. I can get into the science as to why this is happening. Nobody cares. But long story short, what it comes down to is that the government is putting, thanks to the Inflation Reduction Act put into place a couple years ago, the government's putting a lot of pressure on making prescriptions affordable and making drugs more affordable. And they're putting that pressure on insurance companies. And so carriers are trying to find out, again, these are for-profit companies, how do we help facilitate that cost? You're either going to see it in the premium this year, or you're going to see it in just formularies just dying off.
Mm. And that approach is really a market approach that you described. So if the insurance companies are being asked to cover more or more comprehensively prescription drugs, then one company might say like, okay, well, we'll cover the same or similar, but our premiums are going to go up by 50%. And another company might go, well, we think there's a market opportunity here to build more customers. We're going to actually cut our monthly premiums, but our formularies and what we cover is going to be cut as well. Is that what you're saying? That's
exactly. I mean, if you look at it from what makes sense business-wise, they really don't have an option. They have to make a profit on this. And so one or the other is going to be affected. Exactly what you said.
So if there's this, you were talking about standalone Medicare Part D plans, which is what you use if you're either option 1, bear with Medicare, or option 2, bear with Medicare plus a Part D plus a Medicare supplement. But also number 3 is impacted here too, which is Medicare Advantage, because as you know, Medicare Advantage takes medical benefits of A and B and D and rolls them all into Part C, which is Medicare Advantage. So Part D within Medicare Advantage is probably impacted as well. If I have a Medicare Advantage plan, what should I be paying attention to specifically around my drug benefits embedded within it?
Sure. So Medicare Advantage plans are actually getting hit twice as hard as your standalone prescription drug plans because there's something happening as well on the health side of things. So your Medicare supplement, they only have to worry about the health stuff. There's Part B, claims are going up due to the effects. We're still seeing the effects of COVID, people delaying care, people delaying. So you're getting more serious diagnoses because people, are just now making those claims. And so with Medicare Advantage plans, not only do they have to handle the rising cost of healthcare and the rising cost of claims, especially for the turning 65-year-olds, they're also having to figure out how are they going to pay for these drugs, these drug benefits, and handle the premium. And again, people know that what makes Medicare Advantage plans so attractive are going to be those really low, if not $0 premiums. So a lot of the times they don't have the opportunity or the option to raise up that drug cost because it's really difficult to go from a $0 premium to a $64 premium. So you're going to see them
Yeah,
not
you're
so
going to
much.
lose a lot of customers that way.
Exactly.
Yeah.
It's a lot harder to go from 0 to 64 than it is to go from even like 30 to 90. The psychology behind it. So you're seeing these Medicare Advantage companies really have to cut elsewhere because a lot of them are going to be unwilling to get rid of the things that gain the market's attention, including the low premiums and the new and shiny, but they still have to have a cost for these drug plans. So I think a lot of that, what you're going to see is, again, a lot of these companies are really focusing on the dual special needs. What I mean by dual special needs are going to be people who have access to both Medicare and Medicaid, because Medicaid will help with low income subsidy, will help kind of pick up that Part D bill. They'll kind of help pay for those prescriptions and the drugs. So you're seeing a lot of Medicare Advantage companies shift their focus into some of those more specialized markets. And you're seeing some of the plans that are, again, designed for the average 65-year-old, 65 and up. You're seeing some of those plans maybe take some of those hits on what you mentioned earlier, those secondary benefits, those ones, the benefits that don't show up on the insurance card.
Okay. So pay attention to what your Medicare Advantage plan is doing.
Yes,
Because if your premium is staying the same, that probably warrants more inspection because
yeah,
the market has changed. The costs that the insurance company have to bear are greater than they were in prior years.
exactly. It's not going to be, and again, they're not going to affect the sexy benefits. They're not going to affect what people talk about, what Joe Namath and these advertisers. They're not going to affect what they're talking about. They're affecting your actual healthcare benefits. So it's really important. Again, there are still some wonderful plans out there, some amazing plans with really rich benefits. You just got to do a little bit more research than what you're probably used to doing.
Yep, makes sense. Okay, I'm going to pivot to Medicare supplements.
Okay.
Because Medicare Part D and Medicare Part C, Medicare Advantage, really run by very similar rules, right? In the
Mm-hmm.
annual election period, you can change your Medicare Advantage plan regardless of your health status during
Mm-hmm.
this time. You can change your Part D plan regardless of your health status at this time. There's no underwriting, there are no medical questions. You just go. If you're
Sure.
on Plan A and want to move to Plan B between October 15th and December 7th, work with your agent, do it yourself. You can do it. No questions asked. This is your time to make your annual change.
Sure.
Medicare supplements don't play by those rules because Medicare supplements are state regulated. Yes, they're federally regulated, but they're state regulated at the state level. And they don't play by the same rules because A, they're older. They've been around for a very long time.
Sure.
So they're kind of entrenched. But B, they have different schedules. They don't have the same schedule. They don't have the same schedule of when you get your renewal letter and know what your rate is going to be for the next year.
Sure.
Whether or not the company's going to stay in business. I mean, it's a whole kind of other thing, even though it's part of the Medicare insurance ecosystem. Let's talk specifically about what you're seeing in the Medicare supplement space.
Yeah. And I just want to remind everybody too, if you're listening to this podcast and you're like, well, they've not talked about me or hit me at all, I'm a med sup person, I will let you know that the number one time of year where people change Medicare supplement plans is in the fourth quarter, is during AEP, because you're reviewing your drug plans and trying to find extra dollars. So this time of year absolutely still affects you, just not in the same way. The Medicare supplement market right now, for lack of a better term, they're a little nervous because of the popularity that Medicare Advantage plans have offered and the option of I can get great benefits and even more benefits and pay much less. The Medicare supplement, what we're seeing right now, because of, again, a couple factors that come into it. I know we're all sick and tired of talking about COVID, but COVID is a lot of it's affecting Medicare supplements right now, as well as, again, the growing popularity of Medicare Advantage. And finally, our turning 65ers, our baby boomers who are finally reaching Medicare age. To go into that a little bit more, what we're seeing for trends, let's just focus on the turning 65ers. What we're seeing as a pretty significant trend is that what used to be the most popular, the most profitable book of business for insurance companies are actually causing the biggest losses. These the turning 65ers on average are actually costing these insurance companies a lot of money. And that is because the claims that they are submitting are by far outweighing the premium that they're paying in. So they're costing these insurance companies dollars, not making them dollars. And it's completely understandable why. We're finding that many people turning 65 are delaying significant surgeries, either because they want to wait until they're on their Medicare benefits or because they want to wait until they retire and actually have time to recover from that. So that's something that the insurance companies are having to adjust to. What used to be most profitable is now starting to see like, hey, this is actually, they're changing their marketing strategy. They're saying, we maybe don't want the 65-year-olds. We may not have the nicest premiums for the 65-year-olds. We'll be more attractive to people who've been on Medicare for a while. And so what a lot of people are seeing with that is higher entry cost, higher cost to a Medicare supplement than what they may have been led to believe was going to actually happen to them. And then you're also seeing maybe some more premium increases down the road because they have to make up for that loss with the 65ers. They have to make up for that somewhere. So you're seeing, again, we kind of hit on this earlier, but companies that are coming out saying, we're going to come out really competitive, really affordable, really cheap. You're starting to see a year or two in, they have to accommodate and you start seeing some rate increases. So if you're in a state that, offers these guarantee issue rules, we're talking about these anniversary rules. We haven't really hit on that yet, but a lot of these states are seeing that seeing our people are getting enrolled into these plans and then having some significant rate increases that they just can't afford. So states are trying to, again, these are state ran, they're trying to cut a lot of these beneficiaries a break by saying, okay, so for example, I'm from Missouri. So we have, and this is not a new rule for us, but we have what's called the Missouri anniversary rule. That means at my policy anniversary, I can switch to any plan or any carrier that I want, but I have to stay with my same plan. So if I'm on a plan G with Mutual of Omaha during my anniversary, I can switch to a plan G with United Healthcare and not have to go through any medical underwriting. That sounds amazing. That sounds really awesome. It sounds like you're giving beneficiaries an opportunity to shop and remain on low cost plans. But if you look at Missouri's premiums compared to somebody like Kansas, where they don't have those rules, Kansas premiums as a whole are a lot lower than ours because they don't have to accommodate for those loss ratios because there's not a bunch of sick people switching plans. And so if you are in a state that's recently reviewing what those rules are, I'm looking at Illinois, Missouri, Louisiana, Nevada, there's so many of them that are coming out. Oklahoma just launched one. Just be prepared that sounds great on paper, but you might be expecting to see some rate increases that you may have not been familiar with in years past.
A very good point, and you're right. The states are making those rules for the benefit of the beneficiary,
Absolutely.
right? Because if you don't have those anniversary date or there's birthday date rules in there that you can do in your particular state what you just described, which is, all right, I turned 65, I bought product A, a plan G, that's up plan G. Turned 70, I don't like this company anymore, or my rates are going up. What else is out there? In non-birthday rule or non-anniversary states, you're kind of stuck.
If you can't answer health questions, if you're,
Right.
if you're 72 years old and still running marathons, you're fine. But
yeah,
if
you can go through
have,
medical underwriting with another carrier and get it. But if you're not running marathons
right,
and you're getting over cancer or had a heart attack or had a stroke, you're going to be in that MedSup program unless you drop it and go back to original Medicare.
Absolutely.
So what I think states are doing and what you're saying is I don't like that. And they want to give people the option to switch plans and save money, which is great from the consumer standpoint.
Absolutely.
Right? The problem with that is you're right. The insurance companies know that and see that and are going to price accordingly because here's another way I'll explain it. And this kind of goes back to Medicare Advantage and D, and you touched on it. When you're on a Medicare Advantage or a Medicare Part D plan, the federal government is sending a certain amount of money, and I'll say subsidizing that care by sending some money to the insurance carrier, right, in addition to whatever premium you're paying to pay for your care.
Right.
The Medicare supplement plan isn't getting any of that.
No.
So if you have a $200 monthly premium, right, that's going to be $2,400 a year for the insurance company. And you go, oh, that's a lot of money to the insurance company. It is, unless you go into the hospital in that year and charge $500,000.
Yeah.
Those numbers don't work for anyone. I mean, if you're running a small business and you have $2,400 of income, yet you have $500,000 worth of expenses. It doesn't matter. Yeah, I'm not a math whiz either. But you get the point, right? So there is no subsidy. There is no additional funding. So basically, it's old school insurance, right? You have a pool of people. The healthy ones have to pay the $2,400 a month or a year, right? And not use it to help the other people who are also paying $2,400 a month, but charging $500,000. That's kind of the whole people in the pool. And the more people in the pool you have, the fuller it becomes. The more one or two people in the pool get sick, well, they're fine because everybody else is paying for them. Sure. And when that breaks down, or people leave the pool in these state-based rules, carriers are left with some options. Take losses, right? Active losses, real money, or raise rates. And that's what you're saying. That's what it's looking like they're doing.
And it's magnified because unless you're in a community aged or community rated state, the people who are paying the lowest premium are people with the highest costs, or the people who are experiencing the most claims. So your 65-year-olds, because they're aged younger, it's assumed that they're healthier, and that's how the actuaries and that's how they build these rates. But when we're seeing that people are waiting until they get onto their Medicare and Medicare supplement to submit these claims and to have these procedures done, the most money being spent is coming from the people who are paying the least amount in. So it just kind of magnifies that effect.
Yeah. That's not a great scenario you just painted.
I don't want to bring it down and be sad. It's still, it's just incredible research and just trends to keep in mind.
Yeah, no, that's really good. So if someone is thinking this time of year, and I get this question all the time, right? It's kind of a cost benefit analysis, but it's also it's a hard question to answer. If someone is thinking of moving off a Medicare supplement because they've been on it for whatever, 2, 3, 5, 6 years, and the rates have gone up, and they'll get another renewal notice and say, oh, surprise, it's another 14%. And they go, gosh darn it, my neighbors are on these programs, but I'm a little suspicious of it. It's unfamiliar. Medicare supplement's easy, right? No provider networks, right? You on a plan G, all you have to do is satisfy your Part D deductible, and then you don't pay any more in medical. They're sweet. I mean, we call them in the industry Cadillac plans, because that's what they are. They're very little. Yep, easy as it gets, and provides the most, I'll say, comprehensive financial protection that you can. But those premiums are real, and especially if it's mom and dad,
right? And
you're saying, that's 2 premiums a month you're paying, and Part D's going up potentially. That's a lot of money coming out of your pocket now. That regardless if you get a Social Security check increase this year or not, it's a lot of that's going to be eaten up by the increases to your premiums. So, someone's in this scenario and they're going, I'm on a med sup, I love it, but man, I don't love the prices.
Yeah.
If they're thinking of moving to a Medicare Advantage, what thought process should they take? What thought process could they embark upon?
I love that question because I think something that we find really interesting is that Deft Research has actually looked at this demographic of people, saying if people who they call them the switchers went from a Medicare supplement to a Medicare Advantage, and they're finding that over half of the individuals ended up regretting it, not because the plan was a bad plan, but because they were undereducated about what that move actually meant. So I work with a lot of people who have moved from that Medicare supplement and made the jump into Medicare Advantage plan and have been incredibly happy doing so. Unfortunately, there isn't a blanket answer for this because every situation is different based on, again, lifestyle and budget, and honestly, what you have as a priority. The one thing I would mention if people were asking me this question, because I do get this question, and it's simply taking a look and saying, when do you want to pay? When do you want to pay this money? Are you okay? And how do you want to budget your healthcare fund? Do you want to pay for it in the beginning, knowing that the rest of it is taken care of? Or do you want to say, let's go ahead and save this money away, and instead of putting this premium here, let me save it for a rainy day and make sure that if I do go in the hospital for an extended stay, if I do have to see somebody on my network, I feel comfortable being able to cover that after the fact. Am I disciplining myself well enough to know that I'm not paying it here, but I may have to pay it back there? Either answer is a good answer. It just has to be what's right for your priorities. Other thing I would mention is that if you are wanting to say, like, I'm hearing a lot about this seems pretty, I need a significant amount of dental work done, or I need, I really am interested in paying, a $0 premium on this. What I would say to them is this your first time ever going on a Medicare Advantage plan? And really look at the history of their coverage, because you may not know, you may not know what you've had in the past. But what CMS has done is allowed people they call it a trial right period. That if you've been on a Medicare supplement, I don't care if you've been on a Medicare supplement for 1 year or 15 years, if you've only been on a Medicare supplement plan, they give you 12 months to kind of look at what it's like to have a Medicare Advantage plan. If within that next 12 months you say, you know what, I don't like it, it's not what I thought it was going to be, my doctor just left the network, because that can happen in the middle of the year, then you have a 12-month window to go back to that same Medicare supplement company and that same Medicare supplement plan and basically act like nothing ever happened. You can then enroll in a standalone drug plan, and it's kind of all is forgiven. We kind of pretend like the last 5-6 months, however long you were on there, pretend like that didn't happen. The exception to that is if you're on a really old Medicare supplement and they no longer offer that company or that plan anymore, then you do get what they call a guarantee issue right to try another Medicare supplement company or plan. But we do, again, that does happen. So if you want to try a Medicare Advantage plan for the first time, just be conscious you do have an opportunity, but it's only 12 months. So get the most out of it, see if you actually like it, and then we can put you back on that med sup.
Makes a lot of sense. Mm-hmm. Let's flip it. Let's say I'm on a Medicare Advantage and sure, I'm past my guarantee issue rate, right? I'm 72, and I've been on a Medicare Advantage for a year or 2 or 3 or 4, and I don't like it, and I do want to change my coverage to a Medicare supplement. What's that process look like?
Yeah, absolutely. So what's funny about that process is that timing is everything. So know that if you are, you've been on the Medicare Advantage plan, you no longer qualify for a trial right, then what you will have to do is you will have to answer medical questions, which means that you have to qualify for that Medicare supplement. The last thing you want to happen is to enroll into a Medicare supplement, enroll into a standalone drug plan, and then come January 1st, you find out that, well, this condition, we don't cover that, or you were denied coverage due to your health or something that you may not be familiar with. And come January 1, you now have original Medicare. You're in that first option we talked about, the Medicare and you have A and B, and you're covering everything else outside of the drug stuff. So timing is everything when it comes to this. If you are wanting to make that route, you have 2 options. If it's early in AEP, I'm talking October 15th through like November 10th would probably be where I would feel safe doing this. If you're in that first few weeks of AEP, go ahead and submit a Medicare supplement applications. Go ahead and qualify underwriting, work with an agent to find out which company is right for you. Once you get told, yes, we accept you, you're healthy enough, here's the premiums that we're going to have for you, and you're happy with that, then go ahead and enroll in a standalone drug plan. What a lot of people don't know is that when you enroll in a standalone drug plan, CMS will say, well, you can't do that. You can't have a Medicare Advantage plan and a drug plan. You submitted this drug plan. We're going to go ahead and kick you off this Advantage plan effective January 1st. So if everything goes to plan, January 1st, you have A and B of Medicare, your Medicare supplement, and your drug plan. If you miss that window, and the reason why I give that window is because sometimes when you have to answer medical questions, Medicare supplement companies can take a long time to actually go through and underwrite you. They can take a long time to make a decision because they're really busy. So if you miss that window, then we have something called the open enrollment period, not to be confused with the annual enrollment period, which again,
yeah, but as I said, they are 2 different things. It drives me nuts that people use them as synonyms. They're not the same.
They're not interchangeable. They have
memo to Medicare marketing people in Baltimore. Stop calling it the OEP in
Someone fix
December
it.
and November and October. It's not.
Someone fix it. But
Use
during
your
the
own acronym. It's the annual
exactly.
election period, the
Well,
AEP. All right, go
but
ahead.
let's
I'll
not
get
be
off my high
confused.
horse.
No, but like to your point, did you know, again, I'm sure you know this, but to our listeners, there are 3 different types of OEP. None of them including the AEP, which people use interchangeably. There is 3 types of OEP. This is maddening and of course so confusing.
Yep.
But the OEP that I'm referring to, which is referring to Medicare Advantage OEP, goes from January 1st to March 31st. And I call this kind of the mistake fixing one. Now, this will only affect people who are in a Medicare Advantage plan going on January 1st. If you are in a standalone drug plan, this doesn't affect you whatsoever. So those people who are on a Medicare Advantage plan starting January 1st, they get a one more chance. They get a one more chance to be like, are you sure? Are you sure you want to be on this particular plan? And during that time, a beneficiary can then underwrite through a Medicare supplement plan. Then they have a little bit more time. You have 3 months at this point. You can enroll into a Medicare supplement then. Once your plan, and only once you are confirmed that your plan has been approved and you have coverage, go ahead and enroll in that drug plan. It'll kick you off the Medicare Advantage plan, and you can go throughout the year on your Medicare supplement. And if you are somebody who's worried about the premiums of your Med Sup, worried about the premiums of your prescription drug plan, there's a lot of money-saving things that you can do. One of my favorite websites is actually beneficiaries.org. It is a website that you can go to. As an organization, I am not, I'm promoting it because I've used it with our own clients. But you're able to go on there and try to find different ways to pay for different services. It's not Medicare related, but they can help you find ways to pay for things like maintenance that you need in your home. They can help you find ways to pay for those really high cost drugs that maybe is a tier 4, tier 5. Maybe it's too expensive with your drug plan. So finding alternative ways to help pay for those plans. So it's a really awesome way to kind of find extra money to where you don't have to be so concerned with your rising cost of healthcare. Because at the end of the day, if we don't have access to healthcare, that's pretty scary. We don't have access to a lot. So a lot needs to be considered when you're making those choices.
That's a great call out. There are lots of state-based, federal-based, local community-based resources that can help out in a lot of ways.
Sure.
Premiums, drugs, benefits, assisted living, caregiver help. It's all, and you're right, benefitscheckup.org is a great place. And there are others, but that's a great place. And I know a lot of insurance agents use them.
Sure.
Before I move off med subs real fast.
Yeah.
If I'm thinking of buying a Medicare supplement and I do find myself in a situation where I'm going to need to be underwritten, are there rules of thumb that apply? In other words, I already mentioned a couple of them. If you've had a heart attack, you're probably not going to be accepted. If you've had a stroke, if you've had cancer, you're probably not going to be accepted. Are there broad and general rules like that? You're like, you're not going to be accepted, so you probably should stay on original Medicare or get a Medicare Advantage.
Yeah, a couple of them that are going to be obviously your significant, intense diseases or illnesses. End-stage renal disease, you're going to have a hard time. A lot of mental illnesses, diagnosable, again, intense mental illnesses might be something that you need to double check. What's really interesting is that a lot of carriers have really loosened up. I think what MedSup carriers are doing to try to recover from losing a lot of the market share to Medicare Advantage plans is that they're coming out with these niche products. For example, diabetes. If somebody was insulin dependent diabetic 5-10 years ago, they were pretty much on like a non-insurable list. However, right now, if you're taking less than 100 units of insulin, there's several plans out there that are happy to accept you and have that calculated into their premium. So they're not worried about your insulin dependency. So my recommendation is never hurts to double check. Again, if you have been diagnosed or receiving, another one is like, are you currently receiving treatment for something? So if you are, let's say you're getting, or not insulin shots in your knee, that would be weird. If you're getting, what is that gel, cortisone shots for your knees or joint, things like that, a lot of companies will consider that ongoing treatments. So if you're receiving, or if you're currently in physical therapy, if you're currently receiving cancer treatments or have in the last 2 to 5 years, a lot of carriers will say, well, that's an ongoing thing. That's a pre-existing thing. We don't want to start taking over that cost. But if you've had a break in treatments or you haven't received treatments in the last 2 years for a lot of carriers, then they oftentimes are completely fine with that previous diagnosis. So it never hurts to double check. It never hurts. If you, again, in some significant chronic illnesses, you may have a harder time, but it never hurts to double check.
Yeah, and each company has its own rules in Medicare supplements. So
Right.
company A may say no, but company B may say yes. Company C
Absolutely.
may say yes, but your premium's going up, or we're not going to cover this for a period of time or whatever, right?
Exactly. Yeah, exactly.
Well, then I'll just say it because this is, I think this is what I would recommend to my family members. If
Sure.
that's your case, use an agent. Your agent is going to know this stuff. Your agent's going to
Mhm.
walk you through this instead of going to 85 carrier websites and trying to figure and making 85 applications. I got you.
Yeah.
That's a real benefit of using an agent that knows what he or she is doing.
Oh my gosh, I can't say it loud enough. Agents, they're in it, they eat it, they breathe it. Most of the time, if you're working with somebody who's independent, then they're able to look across many different carriers, and they're working for you, and you, the beneficiary, you're not paying them. The carriers pay the agents because they want to make sure that the agent is taking care of you. It's really important to work with an agent because then when there are issues, when a claim doesn't get filed right, or when you have questions about your medications, you're not calling 1-800-Medicare. You're not calling an 800 number. You're calling the person who helped you with that plan. So I am a huge advocate. I'm passionate. I guess I didn't realize how passionate I was until this exact moment, but I'm really passionate about making sure people are using insurance agents because it is in your benefit for sure.
I didn't ask this earlier and I had it in my notes, but I'm going to ask it now because I already know the answer to it, but I want you to say it. If you're on a Medicare Advantage plan, we already talked about what costs are now being borne out by Medicare insurance companies, all
Mhm.
types of Medicare insurance companies. There's something that I write about in the book a lot, and probably not only because it's really important and people
Mhm.
miss it, but also because it's really fun to say, and that's the MOOP.
The
The
MOOP.
MOOP. The MOOP.
Yes.
The MOOP stands for maximum out of pocket. MOOP. I'm going to say it again. MOOP.
MOOP.
A MOOP has to be on every Medicare Advantage plan,
Mhm.
which means it's kind of like when you're, if you're on your employer's insurance, right? At some point in there's a little line that says, they call it stop loss or maximum out. Well, yeah, maximum annual year maximum. Basically, like
Mhm.
if you have a really bad health year and you pay $10,000, after your out of pocket is $10,000, we cover 100%. Like we're not going to make you pay $150,000. At some point, the insurance companies go, okay, you've had enough. This is your maximum financial exposure. You've paid it.
Mhm.
We're going
Mhm.
to take it from here, right?
Mhm.
Okay, same thing, same concept in Medicare Advantage. Every plan has to have a MOOP. And if you have a plan like a PPO, that MOOP can be in network lower than out of network. So if you're
Mhm.
going out of network, the costs are higher, the maximum out of pocket is greater. If you stay in network, costs are typically lower and the maximum out of pocket is typically lower. A
Right.
couple years ago, very quietly, the Medicare CMS allowed insurance companies to raise that MOOP,
Mhm.
and they're doing it again in 2024, right?
Mhm. Mhm.
Have you seen, looking into your crystal ball, in all the plans and all the states and all the people you talk to, have you seen carriers going up to that MOOP limit and increasing that as part of what they're trying to do to tackle the healthcare costs?
It's what we have gotten used to in years past is saying the MOOP's up here, but we're going to keep it right here, right? And just a reminder, Medicare Advantage plans have these MOOPs. Original Medicare does not. So on paper, like having a max out of pocket is absolutely better than not having a max out of pocket.
Correct.
But the idea is that we're used to people saying, yes, there's a ceiling over here, but for the majority of our plans, we're going to keep that ceiling down here. We can choose to say, yes, we're going to go all the way up, or we're just going to keep it at this lower level.
So what you're saying is, and I say this
Yeah.
actually everywhere. I'm like,
Yeah.
look at your MOOP, and if it goes above $4,000, you just need to shop. But that MOOP
Yeah.
maximum that can be there is getting higher and higher. Sorry, go
Yes.
ahead.
No, what I'm saying is that you're exactly right, is that the plans this year are starting to actually utilize and that ceiling. You're starting to see that people are taking the maximum allowed, maximum out of pocket, and applying that to their own plans. And again, being really quiet about that, not necessarily wanting to advertise that they're maximum out of pocket. So what we have been seeing are the plans with the Part B givebacks, these rebates we talked about earlier, these plans with the $5,000 dentals. We're seeing those plans take the cost out on that max amount of pocket. Not all of them, but a lot of them are. So making sure that when you are shopping for your plans, look at those max amount of pockets. And you know what? You may decide that like, hey, this max amount of pocket, same thing with Medicare supplement premiums. Your Medicare supplement premium annually may be less than that max amount of pocket. So you want to look at that when you're comparing your Med Sup to a Medicare Advantage plan. But for the Medicare Advantage plan, again, those can change year to year. They are changing this year. They are going up, in some cases pretty dramatically. So definitely something to pay attention to that you may not have had to in years past.
I could talk to you for obviously another hour. But let me ask just a couple of other questions that I think are germane. We didn't really touch on provider networks much.
Sure.
What you said was true, which is, provider networks aren't set annually. If a doctor moves, leaves, decides they don't want to be a part of the network, they can quit mid-year. And so you can be stuck. Stuck is the wrong word. You can have your Medicare Advantage plan, for example, that uses a network. And you're going to your doctor and you can walk in June and the doctor goes, yep, we don't take that anymore. You can't change. You're going to have that plan until you decide to change it and find one that's in the doctor or in the network, or find another doctor. And that's just the way it is. It's not that's one of, I think, the downfalls or the annoyances of Medicare Advantage. They do come with HMO and PPO networks. Medicare supplements don't. All they have to do is accept Medicare assignment. And that's 99%, ish of all doctors and hospital systems out there. So it can be a big difference.
It could absolutely be a big difference for sure. That's one of the top reasons why we see people go the Med Sup route isn't financial at all. It's freedom to know that I don't care if I have a grandkid in New York and a grandkid in California, and I'm taking my RV back and forth. I want to make sure if I need help, I need medical care, I can see it without having to work with paperwork. And so that's what we're seeing. A trend that we're seeing is that finances actually are not a lot of the reason why people are shopping Med Sups versus Advantages. It is that choice and that freedom.
So if you're in a Medicare, and I agree with you 100%, and that comes back to your lifestyle, right? You keep saying, what's your lifestyle? It's not just how sick or unsick or, how well or unwell are you? How many prescriptions do you have? What are they? Yes. And what's your life like?
Yes.
Do you run? Do you travel? Do you visit? Do you go overseas? I mean, this is all the mental math you have to put yourself through, not just dollars and cents. Anyway, I digress. What have you been seeing trend-wise around Medicare Advantage networks? Have you seen them getting bigger? Have you seen them getting smaller? Have you seen them becoming more in line with certain hospital systems versus others? Are they getting bigger? Are they getting smaller? Does Company A have a completely different one you're in Missouri. I'll say St. Louis. Does Company A have their own set in their networks and Company B has a completely different set and they don't share? Like what does the network thing look like over the years?
I love that question because it's actually you're seeing completely different things happening at the exact same time, but they are still trends. And so when we're talking about these, I call them the big boys. We're talking about your UHCs, Aetnas, Humanas, your big guys in the field. We're seeing their provider networks actually expand. They're introducing something it depends on the carrier, but called national networks that are saying that it doesn't matter if you're in Missouri, Florida, or California. If you find somebody that accepts our company, they don't have to accept your certain plan. They just have to accept our company. And so there's really opening up for my travelers out there. It's really opening up Medicare Advantage as a good appeasing option for them because that network has tremendously expanded. On the other side of that, whenever we're seeing new carriers enter the industry, new Medicare Advantage plans, we're actually seeing really reduced networks, and they're calling them value-based providers. That's what I'm trying
Okay.
to say. You're really starting to see these smaller Medicare Advantage companies, these more, and I say smaller, when I say smaller, I mean regional, these more regional Medicare Advantage plans, we're starting to see them form really tight-knit relationships with the provider. So they're not accepting as many, but we're saying the ones that we do work with, we work with incredibly closely. So that eliminates things like the waiting periods, or when people have to go like through some of the step therapies. And when you work with somebody who is one of those, again, those value-based providers, those ones that are working really with a limited network, you're actually seeing better client care because the provider and the carriers, it's a slower waiting period for a carrier to actually approve a procedure. And oftentimes the carrier doesn't need prior authorization. Oh my gosh, that was so hard to think of. They
Yep.
don't require prior authorization in a lot of these smaller networks. So you are seeing, again, to answer the question, you're seeing the trend on either side. It just depends on what's important in the lifestyle of that consumer. If they want immediate care, really focused care, but a Medicare Advantage plan is appealing to them, then the smaller regional carriers with the narrow networks are really solid options. They're amazing. But if you have somebody that's, again, a Medicare Advantage plan is appealing to them, but they want more of that freedom, then some of those larger carriers offering the national networks might be a good option for them.
What a wonderful answer and very insightful. Thank
Thank
you
you.
very much.
Of
So
course.
even within Medicare Advantage plans and
Mm-hmm.
Medicare Advantage companies, the way you're able to consume your healthcare benefits can be very different based upon the network you have access to and the type of providers that are in that network.
It's a rabbit hole. Let me tell you, if we have 7 or 8 more hours, I could be happy to educate you. No, and I know you know all of this, but it's just, again, points to why it's so important to work with somebody who does keep up to date with this. Because how on earth are you, a beneficiary, supposed to know this stuff?
Yeah, I made this up, so I'm a little proud of it. But I see from GED to PhD, this stuff is confusing for everybody.
Yes, absolutely. I love that. I'm going to seal that for sure.
Please take it. Listen, Olivia, this has been really comprehensive. I That's so much information, and you know what? I don't know it all. I learn stuff every day. I learn stuff in this conversation because even though we both have done this for well over a decade,
Mm-hmm.
it's changing all the time, and it's
Mm-hmm.
our jobs to keep up with it.
Mm-hmm.
And you know, it's a lot to keep up with. So this has been really clarifying, I hope, for a lot of people listening and watching, but also for me. So really, thank you very much. What question about Medicare did I not ask that I should have?
Yeah. Um, the only thing that I think I would want to talk about, maybe for another episode, I'd love to come back, but it's going to be all the things that Medicare doesn't cover, which I think is actually more important than a lot of the conversations we have about Medicare supplements, Advantage plans, and drug plans, is making sure that you are, as a beneficiary, protecting yourself against things like the cost of cancer, things like medical, things associated with your teeth, gums, knowing that hearing loss is actually one of the number one causes of depression in people over the age of 65. And these are things that you could help finance and help protect yourself against, but they're not the questions that people are asking. Is how do I protect myself against, the non-medical costs of cancers and things like that. So there's so much more to discuss. And I just think that if to everybody listening here today, I encourage you to ask your agent, where is Medicare leaving me a little high and dry? Because there's a lot out there that's not being discussed.
I agree with you. Long-term care is the biggie.
It
Medicare
is.
doesn't cover long-term care.
No, and
The
it's so
transition,
confusing.
yeah, the transition, like short-term care. Everybody knows
Mhm.
long-term care, right? We all know how expensive it is and how
Sure.
hard it is to get underwritten, and how many companies don't offer it anymore.
Mhm.
Um, Short-term care coming out of the hospital and skilled nursing and transitioning back into the home, there are
Mhm.
gaps there.
Absolutely.
Some of those gaps, I list all of the gaps in my books, and so I can't remember them all, but they're all there, and
There's a lot.
I can't remember them all because there's a lot. But there's a lot of areas and a lot of ways to at least partially financially protect you or prepare for them. That you're right, we didn't discuss the gaps of original Medicare, some of which are covered in Medicare Advantage plans or
Sure.
attempt to be covered, but some
Sure.
not.
Mhm.
I would love to have you on to talk about those again, but also I want to do this again next year. This is a
Sure.
fantastic refresher for everybody.
Mhm.
And I'm going to guess there are quite a number of Medicare insurance agents listening as well. So hello to
Sure.
you. You do great work. Thank you.
Thank
But
you.
from a consumer standpoint, this has been really, really helpful. And I want to thank you very much for the time.
Well, I can't say again the amount of respect that I have for you, that the industry has for you.
Ah,
You're a published author, so congratulations, and getting out there and actually helping the beneficiaries and answering the questions that people are asking. So huge honor to be on. I can't wait to do it again, and I can't say thank you enough. It's been
oh
wonderful.
shucks, you're too kind. You're gonna make me blush. All right, enough of that. Enough of those compliments. Olivia, thank you very much. This was great, and thanks so much for being on.
Of course. Thank you.
The Matt Feret Show, related content, publications, and MF Media LLC is in no way associated, endorsed, or authorized by any governmental agency, including the Social Security Administration, the Department of Health and Human Services, or the Centers for Medicare and Medicaid Services. The Matt Feret Show is in no way associated with, authorized, approved, endorsed, nor in any way affiliated with any company, trademark names, or other marks mentioned or referenced in or on The Matt Feret Show. Any such mention is for purpose of reference only. Any advice, generalized statistics, or opinions expressed are strictly those of the host and guests of The Matt Feret Show. Although every effort has been made to ensure the contents of The Matt Feret Show and related content are correct and complete, laws and regulations change quickly and often. The ideas and opinions expressed on The Matt Feret Show aren't meant to replace the sage advice of healthcare, insurance, financial planning, accounting, or legal professionals. You are responsible for your financial decisions. It is your sole responsibility to independently evaluate the accuracy, correctness, or completeness of the content, services, and products of, and associated with, The Matt Feret Show, MF Media LLC, and any related content or publications. The thoughts and opinions expressed on The Matt Feret Show are those of the host and The Matt Feret Show guests only, and are not the thoughts and opinions of any current or former employer of the host or guests of The Matt Feret Show, nor is The Matt Feret Show made by, on behalf of, or endorsed or approved by any current or former employer of the host or guests of The Matt Feret